Hello everyone and welcome back to our Infection Prevention and Control podcast. I'm Fran, I'm one of the infection control nurses.
And a new voice today. You don't have the regular Jen, you have Kerry, and I'm the Deputy Director for Infection Prevention and Control and work with Fran.
So this is the August edition of our podcast. So yeah, as Kerry said, Jen cannot be with us today because somebody is holidaying in France. So, lucky them. So we're going to have an episode today because we've moved away from talking about our multi-drug resistant organisms, which we were doing our series of. And we're going to be having a look at the Infection Prevention and Control annual plan. So I'm going to hand over to Kerry to just introduce a little bit about it.
Yeah, thank you. Well, it's really exciting to talk about our annual programme of work. I don't think in the past we've been very good at shouting about all the things that we do and even less of celebrating all the amazing things we do, which is actually an awful lot of that is not just the IPC team. It's all down to the amazing team, the staff that work every day on the shop floor delivering really good IPC. So essentially, our programme of work is something we try and deliver over a 12-month period. And we look at lots of things. We look at our previous activity. We look at how our infection rates have been, what we still need to work on, what is our national priorities. That might be a focus. So antimicrobial stewardship, gram negatives, all tend to be a priority of what we need to actually achieve. And then we also have what do we like to do, what's going to be fun, and ultimately about prevention, because often our big part of our job is firefighting and controlling outbreaks, as we all know. And that bit's good and fun at times, but we like to do the prevention bit. That's why most of us come into our job. So we have a really ambitious plan. I will say it's ambitious. Yeah. As Fran looks at me going, yes, it's very ambitious. Yeah. There's a lot to do. But, we have to be ambitious. And actually, Craig had our Director for Infection Prevention and Control had a meeting at Quality and Performance Committee, and our NEDs were like, yes, you are ambitious, but actually that's what we should be, and actually we should celebrate that. But we have a key vision within the team, so we have no preventable infection by delivering safe care. So that work plan has real clear strategic objectives that meets that vision, so that no one gets harmed by essentially something that someone shouldn't really get when they come into hospital. We want to get people better, we don't want to cause them harm. So the 5 key strategic themes, and we're going to have a chat through those, I think, are based around things that we think are going to make the biggest difference. So we look at healthcare associated infections, particularly reducing those. So what do I mean by HAIs or healthcare associated infections? Those are the infections that you get when you're in hospital, normally as a result of healthcare contact. And those are the ones we think we can avoid. We are looking at things related to education and engagement. That's why we do this podcast as one of the examples. We've had some really good things we've done in the previous 12 years with the podcast, but the newsletter and also the Shared Decision Making Council. And I think it's really exciting. We've got Austin Day this year as well, which is great. We've had to even open it out, haven't we?
Oh my goodness, the interest you guys have shown. It's really good. It's great. But I was like, oh my God, I was not expecting that.
We've had to open our room out. That's how many people have come. Now have close to 200 people. Yeah, it's fab. And then we look at things like how we engage with our domestic teams and our facilities teams, and then antimicrobial stewardship, which is really important, and looking about prevention of SSI. So I think you're going to chat a little bit, hopefully, Fran, about what our HAI reduction plan.
Yeah. So we've got several kind of I'd say layers to it. So we've got one section that we call standard precautions. So this is looking at things like making meaningful, usable audits. So as you all know, well, a lot of you might know that we've got the infection control assurance framework. So recently one of my colleagues left who was doing that. So
I know, we miss you, Jake. I know. His amazing IT digital skills.
So I have... I don't know why I've taken it upon myself to take on this.
I think you were. I think you were slightly pushed into that role.
Yeah. So I've had a couple of meetings recently because a lot of it is making obviously reviews and changes to make it a bit more relevant. Obviously, whilst we're still going through COVID and bits and pieces, like making changes to that to make it just more relevant to where we're at now in the preventative kind of role that we're in. So having had a couple of meetings, I had managed to have a couple of chats with, ward managers, people that fill out the ICAF to actually gauge as what's relevant anymore.
It's good to get some user feedback, shall we say?
I know, because otherwise I'm just sat at the computer like, what to say? So that's going to be one of the priorities for this year. So that will be myself that will be having a look at that, and just seeing how we can adapt that to our kind of everyday
Yeah, and we've heard in the past, particularly even the infrastructure, like the IT behind the background, isn't that good, and we hear you with that, because I know we get quite a few phone calls saying I can't put my hand hygiene audit data on. So just to say, we hear you, we're working on it, and hopefully we can get a better, slightly digital platform that will mean that you don't get somebody chasing you for your audits when you know you've already submitted. It's just the IT is not quite supporting it right at the moment.
Absolutely. So it's definitely something we have in mind, and it's something that we're working on. So any feedback from that point, definitely bring it to us. We'll bring it all into the big plan. So that's definitely something to think about. So we're also looking at producing new metric standards to measure effectiveness of hand hygiene. So one of our colleagues, Geraldine, has a lovely machine called a Shore Wash. I think we've mentioned it before. And it's taken a bit of time to get up and running.
Yes.
And Geraldine has worked so hard on it.
She really has.
And I'm sure she can't wait in a lot of ways to get it up and running. So that will be one of the ways that we can ensure that we're using it effectively. I think it's going to be linked to your smart card.
Yeah, that's the plan. So coming to a ward near you soon, so you can come and see how good your technique is for hand hygiene.
Yeah, it's quite exciting. I think I've used one once, and I was like, oh.
Yeah, it's also a bit scary, because particularly when you're the IPC nurse, you should be the expert in it, and you're like, oh, I missed that bit. Yeah,
okay.
All human though. That's the point,
exactly.
right?
So that's one of the other areas working on, and you'll see us out and about with soon. Also, the aim to reduce. One of our big topics that we talk about quite a lot is to reduce inappropriate glove use, and improving hand health as well comes along quite nicely with that. So a lot of it is behaviour changes, and, we understand that after COVID, after a period of like, oh my God, I need to do everything I can to protect myself, to protect others, also trying to understand that gloves aren't always going to necessarily protect you, and you need to protect yourself, and ensuring you've got good hand health, things like that. Absolutely. So a lot of it, is behaviour changes.
Absolutely.
And again, it's just like any ideas as if in your individual area you've got that you think might help with reducing glove use, also from a sustainability point of view. Mm-hmm. We would love to hear it, because we do quite a lot, as you know.
Well, it's really interesting, actually. We just came off a regional meeting. It's one of the things that, as part of our engagement programme, is to continue to support the regional work. And actually, I had a really nice email to say they were really buzzed after it, because we looked at the same other projects we could do from a sustainability angle. And I think we're keen to see, not just with glove use, but whether we could do 3 particular things. So one is about paper cover rolls for couches. Well, there's no IPC evidence that makes any difference, but actually it's a real so one of the programmes we're trying to do is the whole Southwest, if we can get rid of the paper cover for couches. The other one was to see whether we can reduce, and actually I think we might do this in the trust already, so we might be ahead of the game, would be to look at reducing the amount of times we make beds, because we get through so much linen unnecessarily. And actually a trust, I think it's Swindon now, that have just gone through, and they've now only I think they change it every 3 days. So again, from no IPC reason to do it, unless it's soiled or dirty, then obviously you would do it. But just that routine doing it, ticking the box exercise, like we're going to challenge ourselves on some of these things that we do. And the other one was really exciting, was about, and this one's a bit people sitting on the fence with this one, about whether we should remove skin preparation for venipuncture. So when you're taking bloods, should we clean with a wipe or not? Or whether arms should just be clean, visibly clean. So again, there's no evidence that says you should do it with a alcoholic Lexstein wipe. So that might be, again, reducing our wipe usage. So I really love this, challenging the status quo of IPC for the sustainability aspects. So
100%. So it's all coming into the mix. So as I said, any ideas you have, just please bring it to us. Absolutely. And we'd love to get other people involved in it as well, because we're not just like the only kind of team considering it, and
absolutely
we need on the ground experience
completely. I completely agree with that one.
Definitely. So I think that I think, unless Kerry, you've got any other comments?
No,
I think that kind of sums it up from that perspective.
I think it does, and it moves nicely onto another big piece of our work that we're looking at, which is the reduction of bloodstream infections, and that can be all different organism causing. So it could be our MRSAs, MSSAs. So there's what we call our gram-positive bacteremias, or our gram-negative, so E. coli or Klebsiella or Pseudomonas. So we're working really hard on that already, but I think we can do more, particularly in that prevention field. So we're really keen and looking at doing some hydration projects, particularly as we know E. coli in particular, the most common cause of those are urinary tract infections. So if we can get better in hydration, particularly in hotter weather periods of time where we know that those organisms tend to have a higher prevalence, if we can do something in that prevention field, we can hopefully reduce some of those infections. But I think other big piece of that work is going to be looking at catheters and what we can do for urinary catheters, but actually invasive devices generally. So we've got some work to do, but I think we're ready to get on it. And actually, there's a lot in the field now that we can learn from other organisations as well. That particularly for cannulas, I'm working at the moment with our EPR team to try and improve the documentation that we complete at the moment on flow sheets. I think I've slightly bamboozled them and scared them slightly when I had my 2 meetings with them to look. But hopefully that will help you guys on the shop floor to really have a more fit for purpose document that's going to get you a proper assessment of the health of that device. But we're I don't know if with trepidation, we're about to engage in a point prevalence survey, which means we'll look at every single patient across the whole trust to look at if they've got an infection, but also what devices they've got in. So that will be really, really insightful to see where we need to tackle our interventions. But we've got some real good things about where we place, particularly cannulas. We should be moving them to the hands and not to the middle of our arms, the antecubital fossa, because we know that's high risk of bacteremia.
Yeah, definitely. I know. I'm actually quite excited.
I know. That's why your name's on a lot of these things, Fran, and I have to tell you to calm down. I'm like you as well. I'm like, we need to do this. We need to do this. But I think if we, again, like you said, to engage people in particularly the invasive devices, because not only if anyone's ever had one of those devices and they're not pleasant, they're not nice, they're painful, they're uncomfortable, they take away, particularly catheters, they take away that independence, they reduce the mobilisation, we get deconditioning, and then we have infections like pneumonias occur, which means we then give you antibiotics, and then you get one of us pop up because the patient's got C. diff. So our prevention elements have to be so important to our programme, because otherwise we end up having the other infections that we could have prevented.
Yeah, absolutely. And obviously we understand how busy everyone is, but so we're just trying to take out that extra step in your day, just to make it easier for everybody. Completely understand that.
Absolutely. So, if you haven't got that device, you don't have to look after it. That's even easier, isn't it? 100%. So you don't have to do the twice-day checks. You don't have to, particularly if it's an IV antibiotic. I mean, there's some really good stuff that came out from a conference recently that said for a tazocine in particular, so 3 times a day, 30 minutes in the preparation, and it can even be longer at times if you're busy, but that's an hour and a half of your day in a room that isn't with a patient, and actually we can return your time to caring and not standing in a room where actually you could have given this in seconds if it was an antibiotic that was already given. So that's a big, I'm jumping the gun here because that's some of our AMS stuff, but that's my other thing that I'm very passionate about. So yes, absolutely.
Exactly. And I think a lot of this feeds into, especially before I started the job, I was like, oh my God, I obviously knew the basics of what IPC does, but not almost, because I always felt like this was really kind of in-depth stuff. Yeah. It's just such a range of what we do.
Absolutely. That's what I love about the speciality. We promise we're not the clipboard police or the book. I have had some weird names being called, but I promise we definitely don't want to have that culture of negativity. We want to be the enablers, the facilitators, the preventers. We don't want to be the people that slap people's wrists. Honestly, we're not that. We might challenge. We are very friendly. We might challenge with kindness. Yeah. But we are about preventing harm. That's what we're all about, and keeping not only our patients safe but our staff safe. Yeah,
and I think Jen and I have said in the past as well, even if we're hopefully helpfully challenge us back, bring it, we can take it.
Absolutely.
We want to know. So.
Absolutely. If there's new evidence that we don't know, and I think we have to be at the forefront of that, particularly as specialist nurses. We have to be saying, where's the evidence? Why are we doing this? I hear Kerry Gaskin talk quite often that that those sorts of challenges we always give ourselves in nursing. So we do have to make sure we're always delivering evidence-based practice. So I'll happily learn from anybody. Yes. Every day is a learning day in IPC.
Absolutely. And our next little section is on C. diff.
Yes. Well, it had to be there, really, didn't it?
Of course it had to be.
It's going off.
Literally. So having been on a couple of meetings, spoken to a couple of people, as we are aware, we've had a little bit of an increase in the amount of C. diff cases.
Unfortunately.
So it's a big part of our plan to be able to help tackle that and introduce and implement a C. diff reduction plan.
Yes.
So we're engaging in the C. diff system-wide improvement group to deliver reductions in C. diff. Again, we're developing our own trust-wide C. diff reduction plan as well. And also delivering, we haven't. We've already had it. So in June we had, July, I think.
What was it? It was Independence Day.
Independence Day. I was not sure.
I know.
So
she was up.
yeah.
It was very good.
yeah. I think some of the feedback from that has been great.
I think we had about 80 people from across the whole system. So really representative of all kind of health and social cares. We had GPs and care home staff there, as well as our acute colleagues. It was amazing. It was so good. And we had a quiz at the end of it. And honestly, everyone smashed it. They knew more than us, and they could answer it in seconds, all the questions.
Yeah.
So had a really good knowledge gaining day, but also hope and people coming away with their light bulb moments saying, I'm going to go back and talk about this, and I'm going to, people are saying I want to put up these boards in my departments and stuff. So really, really good. I love those, and that's I'm so glad why we've got our study day in October, because hopefully it'll be just as inspirational. No pressure, Fran.
Nothing at all. So I mean that's actually a really good example of something from our annual plan that has been completed alongside our colleagues in Gloucestershire. So that's really exciting. Obviously all built in part of the plan. Another thing that we are looking at, a good piece of work hopefully, is also facilitating patients with C. diff to access treatment, like novel treatments like fecal microbiota transplants. So that is we're hoping that we're able to provide them timely, effectively. So we're looking at ways that they can be delivered, whether they be to inpatients to outpatients. So it's really
it's something we should be really proud of, And I've had a few people now, even Wales have approached us, so they've got I know Wales as a collective, because they have health boards, so they take things a bit more on a wider scope to see how we've done it, because I think we are probably the only one of few that deliver FMT to our C. diff patients, and Fran's like on it now. She's the boss queen for it now, but also across the whole system, which I think is quite unique. I've spoken to about, I think recently in the last couple of weeks, at least 3 or 4 people that have asked for how we've done it. So it's good for us to strengthen our pathways so that we can then also share it. And I'm hopeful, I'm going to do a nudge to Fran, that we can maybe deliver this at one of our conferences up and coming soon, to maybe publish it or put it as a poster, because I think actually I didn't realise how much people are desperate for just how to do it, because I think people really want to, and particularly now it's NICE guidelines, but they don't know how. So maybe there's a poster in the work, or maybe even somebody who might want to quietly do it jointly with you. We're always offering, we'd love to support, particularly our link practitioners, to go to things like these and external conferences. But if you've never written a scientific poster before, or she's already got one in, so Fran's already delivering these things for Jen. But I think there's absolutely something we can do with our link practitioners on something like this.
Well, that sounds really good.
Yes, I just done that.
That'd be nice. I'd like to do that, because we get so much when we come and deliver an FMT. We get so much interest, like from literally every healthcare professional, not just nurses. So
you have an audience, don't you?
Yeah, exactly, 100%. So if we can do anything to make it more effective and streamlined, then that would be amazing.
Well, for anyone who doesn't know what FMT is, it's basically giving someone else's poo donated into their nose. So I just thought I'd say that, just in case you think, what are they talking about? But it's a treatment for C. diff. But yes, unfortunately, is exactly what it says on the tin. It's somebody else's fresh frozen poo, and we thaw it out in our pockets and then put it down someone's NG tube. Exactly. But it works. It's so good. And like 2 days, this patient's completely recovered. So
well, give us a call if you want a very thorough explanation on how
maybe
that
an upcoming podcast with visuals. Maybe.
Well, that's a good idea, actually. Like, giving me ideas all over the shop. So one of the other aims is to try and improve care plans for patients being discharged with C. diff. So we're working with our lovely colleague Reggie, who works she's the lead IPC nurse for GP practices. So we're working with her very closely and some of the community team to be able to develop that, to produce more of a was it, like one kind of Gloucestershire?
Yeah, so it kind of helps that sort of moving between the pathways, because I think a real big focus, I won't talk mostly about the engagement aspects because I think we've probably referred to a lot of already, but a big part of it is that actually we have seamless working. So, all of our patients are in Gloucestershire, all our patients, they're not just our patients because they're in our hospital and then they get discharged or transferred to next. We want to look after them as a whole patch. So a big part of that is our C. diff patients, because they do move between healthcare settings and social care settings quite quickly. So we want to make sure that transition is good, so they've got good continuity of care, and we optimise the management of their treatment, so we don't miss a step because we go back because we've already given them that treatment, and actually it's because we didn't communicate that properly. So I think we're almost there with that. I think Eve's working away, who's our lead nurse, who's our queen of ICNet, is trying to work that up, but I think we're almost there, and actually it's something the whole of the Southwest are working on, as we've already identified that's probably a significant gap, and we've shared that work with the National CDI Collaborative. So hopefully once we've done it, it'll become the standard across the nation. I like forward being part of the start of a revolution. So hopefully that'll be us.
And one final little thing to round off C. diff is to also, previously we've done post-infection reviews for our C. diff patients if they're hospital acquired. So we're also looking to kind of relaunch that in a way, just to make it, again, what can we learn from it better? What can we do differently? And Kerry, you'll probably know more about this than I do. I don't really know.
Is that PSERF?
So, I don't know.
It's a new fangled thing. So it's the Patient Safety Incident Framework. So it's a new way to look at how we review incidents, or particularly, for our case, infections that occur as a result of being in hospital. So it's kind of more of a view to not just doing the same old, we'll go through it, check it and tick the box and this has gone wrong again. I think what we find is we see themes and trends consistently, particularly for our C. diff patients, that actually we're already working an awful lot of hard work on. I mean, we've already talked about some of the things we're doing for a C. diff point of view. What's no point in really spending 2 hours on an investigation that would give us the same results? Why not put that 2 hours on delivering the improvement? So actually there's if anyone's interested, I think there's a webinar that's being recorded. I think it's next week. So if anyone is desperate and wants some bedtime sleeping material, there's going to be one specifically about PSERF and IPC. So I'll give us a bit more insights. But the aim of it isn't for us just to get you all in a room doing the same stuff. It's really about how we improve together, but also learn together for things that we don't know about. So we're not just rehashing the same stuff, which unfortunately I think the PIRs have been in the past. And we recognise that. So do the national teams in IPC. So it'll only be a good thing, hopefully.
Yeah. So that was a little round up of the C. diff point of view.
Which kind of leads into cleaning, really. Cleaning, yes. Which is always going to be on our annual programme of work, but it's even more so at the moment because of the national cleaning standards that we're rolling out. So we're still in the progress with our lovely colleagues from GMS Facilities delivering the national cleaning standards, which has been quite a big piece of work. It's something that's nationally been going on for quite a while, as I say, the 2021 standards, and we were a bit behind, not because of we've been dragging our feet, but because of the resource really that is associated with significant changes in the amount, the types of cleaning we have to do, the frequencies of cleaning, but also the auditing programme around it. So we've got working closely with particularly Nikki, who I think we're going to get on a podcast soon, who's going to help us to give you some illumination on star ratings, which I'll give you that as a spoiler and that's all. But no, I'm joking. So the star ratings essentially like the food rating standards that you get at the moment. If you go to a restaurant, you see 5 stars, it's going to be a similar approach. But one of the things, I guess, obviously we engage and work with them closely, but I think what I just wanted to bring up is the efficacy audits, because it's something that we've been rolling out for what we call our FR1 areas, which are our highest risk areas, so like augmented care, like ITU and our oncology wards, but we're coming to the wards next, which are our FR2 areas. And so essentially the efficacy audit is the thing that we do at the end of the instigation of the programme. So what happens is the facilities team will give you a 5-week programme to really assess that we're doing the national cleaning standards. Have we got enough people? Have they got all the right training? Are the teams on the wards happy that we're doing the right thing? And then at the end of that, we all come together for an efficacy audit, which includes the matron, the ward manager, estates teams, which you'll be glad to hear, because it's always great to have an estates person out on your ward, and they become quite our fun friends, I think, in estates, our domestic teams and ourselves. And we will then assess together whether we're happy that the standards are being met. And obviously we'll have some actions that will need to come from that, but ultimately it's very much a multidisciplinary decision to see whether we're happy that we're achieving the standards, and that happens every year now. So They are hard work,
Yeah.
but I think all the people so far that I've heard from them, particularly when we do a feedback meeting, we have at the end of the month, we do a feedback of all of the reviews, and actually they've gone down really well. And I think when I spoke to Nikki the other week, she said that we're probably the only trust in the Southwest that have really got them running to this standard, and that actually people are getting a lot out of them. I think other people have found them quite, I mean, they are doing wrong, they do take a lot of time, but I think other people have just found them not helpful at all, whereas I think the feedback is at least just to get that opportunity to speak out about the level of cleaning and really rectify problems as a team. It's worth doing. So we've got some tweaks to do, I know. And Nikki recognises that, but I think it's a good thing to do. So really exciting. And the other part of that is getting the matrons involved. So we know that the traditional matron role really came about because of the cleanliness, the commitment to cleanliness. And I always call them the guardians of safety and quality as a matron role. So our big push for our programme this year is to really, how can we engage our matrons? How can we upskill them in that field of particularly commitment to cleanliness? And I'm sure they're amazing already, but I think how we can do things together so that we can learn from them to make sure that they can safeguard those standards, particularly as they'll get complaints and things related to cleaning. So I want them all over it already before it gets to the point where you don't, you have to explore it as an issue.
Yeah, definitely.
So I think that's, oh my gosh, you can say this is our biggest one. Yeah, there's a lot. Let's see what I say about ambitious. I think Fran's going to briefly touch on education, and then
briefly touch on education. But I'm sure, I mean, from the top of my head, over the last, I can't remember how many episodes we've done now, but a lot of the education points of view, I think we've kind of brought up. Obviously we've got our newsletter, which we've seen so many of them like printed out and like put across. I love that. Gives you little warm fuzzies. My newsletter on the wall. So good. It's definitely part of engaging with our practitioners. Engaging with our link practitioners as much as we can. Obviously, we've got our shared decision making council, which we've had really good engagement with recently. We've got our podcast, as well, hopefully you know if you're listening to it. And very excitingly, part of our education programme is developing our own conference, which as we said, we've had loads of people sign up for. So it's going to be a really good day. Absolutely. We've got loads of different speakers, like loads of different kind of topics to discuss. We're going to have prizes, we're going to have stands, we've got loads of things going on. So if you want to come, register by the 1st of September. I'm doing a little pitch for it now. Just give us an email saying that you want to come, where you're from, any dietary requirements. That's our little conference and my pitch for that. So we're also trying to, engage with universities, like university students coming in.
Absolutely.
Because personally, when I was at uni, I don't feel like I necessarily got loads of infection prevention control topics.
And even less, I think, for stewardship, because it's so new. I was the same, I think. Exactly. I think you do one session on how to clean your hands. Yeah, and that might be about it.
have like an OSCE on how to clean your hands, and then that's right. So there are lots of different things going on in education. So again, very exciting.
Yeah, and if you've got any students that are in placement at the moment that would like to come and spend a day with us, I think recently we've had a couple of students where we've had them for the day. They've also been out in the lab as well. So if you're interested in putting a white coat on and playing with some agar plates and some microscopes, then who knows, you can come and join us. That's my pitch, to come and join the team a little bit, selling the dream of IPC to people. But it's always quite nice to have a day sometimes to come out and see what other specialty nurses do. So like you say, you get a bit of oversight about what we actually do. And then I promise we don't just sit there barking orders at people. We're out and about most of the time anyway, aren't we?
Yeah. So that was a very quick rundown, but it's all in the making.
Absolutely.
It's exciting.
And similarly, I think with the engagement stuff, I think that's our other strategic theme, and a big focus of that is how we work not in silos. We have to work with our wider colleagues, so our system, and we're just about to put together a system-wide strategy for IPC, and actually it's more going to be around infection prevention and management, and that's sort of the new approach to sort of IPC, because I think that is more inclusive of antimicrobial stewardship. So it's trying to bring them together. I think they go hand in hand. If you prevent the infection, you don't need the antibiotic. So they're literally hand in glove, pun intended, from an IPC point of view. So it definitely is something we need to be a bit more using that language. So really exciting to be doing that across the system. and taking that further with the region. And we do have a really good regional group, actually. We only had a meeting yesterday, and I think it was about 100 odd people, really good engagement.
Yeah.
And we have a conference that we run, and actually Fran was one of the chairs one of the years for it. And I think, again, another thing I think I twisted her arm for. Bless her, she's so lovely. She says yes to most things. So yeah, and actually we had at the conference we had this year, and we are doing it again next year, and we had some of our link practitioners attend, and it was really good to have them there. They really enjoyed it, and actually it was nice to have like a whole community of Gloucestershire attend, and we had a little photo at the end, and I thought, I'm so proud to see our link practitioners, because most people had just their IPC teams, and I was like, actually, you know what, our IPC team is not just the people that have a badge on that says IPC. But if you want a badge for practitioners, though, maybe we can link practitioners. Maybe that's something we could consider. But yes, it was really nice to have them there and to give them another opportunity to learn. So exciting stuff.
Yeah, really exciting.
And am I going through about AMS a little bit now? Yeah. So what do I mean by AMS? So antimicrobial stewardship. So you might be familiar, like the right drug at the right time. But essentially, what's it say? Less bugs and less drugs. That's how I always think about it. So what can we do to essentially prevent infections so that we reduce the amount of antibiotics we use? And so the antimicrobial stewardship part of our programme is about how we can support our colleagues so they're more aware of what AMS is and what we can all do to make a difference. I think traditionally it's been very much a prescribers club, and we're trying to really move away from just being a prescribers only club. We think our nurses, our HPs, our midwives can all make a difference. And it isn't just about being the person that writes it and prescribes it. It could be about, are you having the right samples? So we know and this is why we always push for it, don't we? Can you please sample? I promise it isn't just a mantra we say all the time, but it's because it means we can narrow our antibiotics down much more sooner. And we have this thing called start smart than focus. So if we can normally start smart when someone's got sepsis, for example, we need to give them antibiotics because they are unwell from an infection point of view. But we want to then narrow that down, and we have this then focus, which could be to narrow the spectrum. It could be to stop the antibiotic. It could be to IV to oral switching, or it could be giving them another antibiotic that's more appropriate because we've now got the sensitivities, or it could be going to outpatient services to have their antibiotics in the community. So a real couple of key themes coming from our antimicrobial show. Okay, there you go. I haven't got my teeth in either. Antimicrobial stewardship programme. It's hard to say that one. We have 15, I think I might have extended to 16 in my last meeting. 15 key objectives where we've got stuff about awareness, education. We've got things about how we use our data. So we've got a lot of things about data for resistance patterns. We've got data on our usage. So we're so data rich, but we just need to understand what's going on so that we can inform some of our interventions a bit better. We also want to look at some real good quality improvement programs. So I mentioned IV to oral switch. Hopefully you've seen our ACE posters around now. A really important part of that.
I had a mind blank. Mouse mats, those ones.
Mouse mats, yes. Like, just telling people how to support the IV to oral switch. So, and that doesn't have to be a prescriber. You can use your pester power if you're on a nurse on a ward round, and if it can release time to care, it can stop you from having to make the antibiotic. But ultimately get the device out. It's all win for me. And really excited to look at our penicillin delabeling. I was at a conference recently that said I think about 80% of some of the penicillin labels in this one particular hospital were inappropriately added and applied because there weren't true genuine allergies. They were patients that said, oh, I remember this when I had diarrhea or something like that. It's not properly an allergy. So there's something in that piece of work where we're looking at challenging the labelling of people that have got those allergies. And why is that important? It means that we can hopefully give you the penicillin, which might be the more appropriate antibiotic rather than potentially several different alternatives, which means you're not less exposed to different antibiotics. So excited about that. This obviously, apart from the IV to oral switch as well stuff. We've got Sequin, so we've got some targets, and we're doing some ward rounds specifically to audit that data. So hopefully at some point we're going to have some metrics to share with people. So not only what our rates of appropriate IV to oral switching looks like, but how much plastic have we saved and how much nurse time have we saved? I mean, it was crazy. I think it was like £200,000 or something a year we could save on just from nursing time if we could reduce the rates to within the Sequin data. And it could be even more than that. And it was crazy amounts of CO2 saved. So
casting our minds back to November 2022.
Yes, for our World yes.
So I don't know if anyone remembers, we had like a big bag of like all of the rubbish that was collected preparing. I think it was like a day of A day of IV.
Yeah, I think it was. I think it was Tazocin, I think.
And
yeah.
my God, the amount of rubbish in that bag.
Yeah.
Like, and you think about the sustainability point of view, it's amazing. And obviously, we're all very committed to the environment, I hope.
Absolutely.
So yeah, that was really amazing.
So really multifactorial benefits from that program work. So if you're interested in Key and would like a little bit more information, then absolutely we'll come to a ward to do a bit of training. But that's really exciting to do.
Yeah.
And I mean, there's so many other things I could talk about from an AMS. I'll be quiet, but I am excited about our potentially a consultant pharmacist role that we're looking at. Again, just to give us some system working around antimicrobial stewardship. So more things to come, but really, really exciting things. And then I think I was going to talk briefly about prevention of SSI, just because it is also... So when we talk about HAIs, we talk about the top three. So we have hospital-acquired pneumonia, we have surgical site infection, and we have urinary tract infections. And I should say, we're doing a plug for Mouthcare Matters. So I should say that Sophie would not be very happy with me if I didn't talk about Mouthcare Matters. And that's a programme to improve oral hygiene and oral health as a means to reduce pneumonias, which we know is probably one of the leading causes from our point of view to needing antibiotics and therefore to predisposing people to C. diff. So really exciting piece of work that we're going to re-engage and refresh people, because we have got some mouthcare champions out there, ambassadors that have done a lot of work that we've done pre the pandemic, but now Soph's back off maternity leave. She's really re-engaged and hopefully going to get out there and regroup. So if you're keen and interested about mouthcare, that's another area that you might think that's not traditionally linked to IPC,
but think it.
But it's actually when my last job that I worked in, we actually managed to get a dental nurse in the IPC team, just because how important it is. And she managed to reduce, I think it was around about, was it 90%? I might be making up percentages now, but I think it was about 90% of pneumonias across the ward by just doing good interventions for mouth care. And it's replicable. So they've seen it in other areas. Holly and I think it's Northampton has just done a similar project, but was able to see the C. diff reduction data as well as the pneumonia data. So really, so look, I couldn't say not so mouth care, but we should also probably put also the built environment as well. Just all coming to me now. Thinking
I was going to say.
You talk about the built environment, Fran, because and then I'll be quiet.
So just considering the built environment, any kind of any building works that are going on, any that you might have seen, there are a number going on in different places.
So much at the moment.
So much.
Yes, can't keep up.
Think about which one's which. So we've always got to have an infection control aspect view kind of on that. So we have these guidance called health technical memorandum.
Yes, which is why we say HTM all the time.
Yeah, it's just an HTM.
Or health building notes, which is the other one. Yeah, we're speaking letters, don't we, unfortunately.
So we're always using those to make sure that we're ensuring the best quality in terms of building works and IPC. We're trying to get more engaged in that, just more involved in general. And also we're looking we're focusing a lot on water safety at the moment as well. Yes. I'm sure, hopefully, you've seen some of our stickers.
Well, hopefully,
they are everywhere.
The step count, it could attest to that, I think.
So there's a really big focus on water safety, and then as I was saying, one of the parts of that is us putting up these stickers, and really from an educational point of view, again, behavioural points of view and stuff like that, really focusing on how we can best ensure water safety for us and our patients, not giving patients water out of a hand hygiene sink.
Yes.
Always good.
Yes. Or putting anything other than your hands in a hand hygiene
absolutely.
sink. Yeah. Don't feed your sinks, people.
Yeah, absolutely.
So leave them alone.
So carrying on, Jen's recently sort of adapted a new water safety educational booklet and things like that. So we've got some really good things going on from water safety point of view.
And if you've not seen it, please shout, because we want to give it to you, because it's really good resource for practical tips about water safety, and which I think unless you've done IPC, I don't think you quite realise the kind of the importance of it, but also actually why we care so much about it, and how we all have a role to play. So as much as we say IPC is everyone's business, really water safety really is, because it's so critical to the safety of our patients. So,
exactly. And another point of view from the built environment perspective is that we're looking at interventions to improve indoor air quality and ventilation to reduce transmission of any airborne pathogens. So we're going to hopefully have some kind of ventilation leads in our team to be able to support specific training and to support our own team expertise, and also placement and maintenance of air purifiers, which I hope
Yes, well, Fran's really excited, same as Jen, really excited because we're a bit sad like this to take all those air purifiers and give them a good clean. So be patient with us. At some point we will be coming to collect your HEPA purifier, which are the ready airs off the units, give them a good clean and changing their filter, and then probably relocating them to the areas where we know we have the highest risk. Because I think they were sort of distributed everywhere during the pandemic, but we know there are particular areas where ventilation is a significant issue. And if you've seen us with a little square box, we're also coming to measure some CO2 levels, which is a good little marker. As Fran with her vacuum cleaner, but also somebody else with a little box just to see, because it gives us an idea from a CO2 level, a bit of an idea of how good the indoor air quality, and the health and safety executive give you some guidance as using that as a marker of assessment. It's not the whole picture, but we know that I'll always do a plug for just a good ventilation, generally keeping your windows open when you can. I recognise at the moment, and we just ran over from the office and got completely drenched in the middle of August. No sun for us, but if you can keep your windows open, doors open, just allow for that natural ventilation to come through. But yes, if your air purifier is screaming and shouting at you, promise we're coming to fix it soon.
Swear.
Yes, promise. Did you get chased down for that? Unfortunately, unfortunately, we're the maintenance people as well as
literally. Everything.
Yes. We do like our Henrietta though. She's really good.
Yeah, me wheeling.
Is it Hetty? Is it Hetty? Isn't it?
My Hetty, wheeling around with my pink Hetty. I've got a couple of comments. I was like, my bestie.
At least we own it, don't we?
Exactly. So from a built environment point of view, I think that is everything.
Yeah.
I mean, we've generally got good involvement. Now we have good contacts with our project managers, and some really good teams working on site and everything. Good
it's always nice to go into some slightly different PPE, isn't it? Go in a hard hat and some steel boots.
Get the high vis on.
So again, if you're interested and keen to see what we look at from an IPC point of view, I mean, we're all engaged from the very beginning, from the design to the final completion. So if you fancy a day out to come and have a look at some of the built environment work we're doing, I'm sure you can come and join us with a hard hat on.
Absolutely.
Who knew you'd do all this in IPC,
I know,
right?
Never expected
and Fran came from sexual health, so
I know it's literally
completely different.
The other way.
Absolutely. So I think that sums it up. I mean, I say sums it up. I think we've been. I don't know how long we've been chatting for, but I hope we haven't bored you all to tears. But I think it just shows. I did say ambitious at the beginning. I had to make sure we got that in.
Yeah.
And we might not achieve all of that. I recognise that, but I think it's important to try and be aspirational. And what we want is you to be involved in that. So that's why we wanted to talk to you about it today, because I think you can get involved. I think that's what the beauty of this programme of work is. It's not just for us, it's for everybody.
Definitely. And we've got a really good, strong team. We've got some really good engagement going on. So we're really excited to see what we can do.
Yeah, and we've just got Maya just join us as well, who's our new our new IPC family. So I think we're a full family now. We've just had Shinsi join us fully now after the comment, and we've got Maya now as well. So again, I'm sure they'll be coming to show their faces out. Particularly Maya is our new member in the next couple of weeks, and say hi to her when you see her.
So I hope that's given you a good old I can't even think of the word. A good old overview as to what we're kind of doing and why you might question some of the things we are doing. It's all in there. It's all part of the plan. I hope you found it interesting to kind of see where
we do have a paper version. So if you do want some extra bedtime reading, we can send it.
It's a long one.
It's also part of our annual report that we have to do every year. And that gets published out to the public. So it's in the public domain. So if any of the I know this goes out externally now. So if anyone's interested and wants to have a look at our annual report for 22-23, and at the end of it, you'll see our annual programme.
All very exciting.
Cool. Oh, thanks for having me, Fran.
It's
really lovely.
Thank you, Jen.
It's hard act to follow, I'm afraid. So hopefully I did her justice.
I was going to say your expertise. I mean, it's needed. So.
Oh, bless.
Because if I'm sat here on my own and be like reading it off the sheet,
it kind of helps when I write it. So there you go.
Yeah, exactly.
I say I write it. It's informed by everybody, but I put the keys to the keyboard. So there you go.
So this, because I think this is our podcast for August. So we're going to be doing another one soon for September. Topic is to be confirmed. I don't really know what I'm doing yet.
I'm hoping it might be star ratings, maybe.
Ooh, yeah.
I might poke. I'll see what I can do.
It's all in the making.
It's like, no, that's not going to be that good.
Yeah.
Everyone's bored of star ratings. Who knows? We'll see what Nikki can do.
But yeah, thank you for joining us.
thank you.
Obviously, as per usual, if you've got any questions, any comments, you can get hold of us on the Global via our acute ICN email or extension 6122 for Gloucester and 3129 for Cheltenham.
You say that. You can say you say that a lot.
I literally say it every single episode. And so, oh God, not again. So just let us know if there's anything we can do, and we'll see you next month.
See you next one.
Right,
Well, I won't, but Jen will.
Yeah.
I'll see you around.
Yeah.
Bye.